Hydrocephalus. Overview and details. Hydrocephalus is a condition characterized by an abnormal accumulation of cerebrospinal fluid, CSF, within the ventricles of the brain, leading to increased intracranial pressure and, in some cases, brain damage. Causes 1. Congenital causes. Genetic mutations, e.g. aqueductal stenosis due to L1-CAM gene mutation. Neural tube defects, e.g. spina bifida, Chiari malformations. Intrauterine infections, e.g. rubella cytomegalovirus. 2. Acquired causes, infections, e.g. meningitis, encephalitis. Trauma, e.g. head injury, tumors obstructing CSF flow, subarachnoid or intraventricular hemorrhage, post-surgical complications. Types. 1. Communicating hydrocephalus, impaired CSF absorption due to arachnoid villi dysfunction or overproduction of CSF. 2. Non-communicating, obstructive hydrocephalus, blockage of CSF flow within the ventricular system, e.g. aqueductal stenosis, tumor. 3. Normal pressure hydrocephalus, NPH, occurs in older adults with normal or slightly elevated intracranial pressure, often presenting with a triad of gait disturbance, dementia, and urinary incontinence. 4. Hydrocephalus ex vacuo, secondary to brain atrophy, leading to ventricular enlargement without increased pressure. 5. Idiopathic intracranial hypertension, pseudotumor cerebri, increased intracranial pressure with no ventricular dilation. Clinical symptoms and signs. 1. Infants, rapid head enlargement, bulging fontanelle, downward gaze, sunsetting eyes, poor feeding, irritability. 2. Children and adults, headache, nausea, vomiting, blurred or double vision, papilledema, balance issues, gait disturbances, cognitive impairment. 3. NPH triad, gait apraxia, wide-based, slow, shuffling gait, cognitive decline, dementia, urinary incontinence. Investigations. 1. Neuroimaging, CT scan, enlarged ventricles, mass lesions, or hemorrhage. MRI provides detailed images of obstruction or associated anomalies. Cysternography to evaluate CSF absorption in NPH. 2. Ophthalmological examination, fundoscopy to assess for papilledema. 3. Lumbar puncture, measurement of CSF opening pressure. High pressure may suggest communicating hydrocephalus. Improvement post-drainage supports NPH diagnosis. 4. Neuropsychological testing for NPH to assess cognitive dysfunction. Treatment. Medical management, limited use. Acetazolamide or furosemide to reduce CSF production, temporary measure. 2. Surgical treatment. Ventriculoperitoneal, VP shunt. Most common, diverts CSF to the peritoneal cavity. Endoscopic third ventriculostomy, ETV, preferred for obstructive hydrocephalus, creates an alternative CSF pathway. Ventriculoatrial or ventriculopleural shunts, alternate routes for CSF diversion. 3. Normal pressure hydrocephalus, shunt placement if gait improvement is evident after lumbar puncture. Recent advances. 1. Shunt technology improvements, programmable valves for adjustable pressure settings, anti-siphon devices to prevent overdrainage. 2. Advanced imaging techniques, diffusion tensor imaging and functional MRI to predict outcomes in NPH and guide treatment. 3. Biomarker research, ongoing studies to identify biomarkers, e.g. CSF amyloid and tau levels to differentiate NPH from neurodegenerative diseases. 4. Minimally invasive techniques, robot-assisted endoscopic procedures for precise surgical interventions. 5. Genetic studies, identification of genetic markers for early diagnosis and personalized treatment, especially in congenital hydrocephalus. 6. Artificial intelligence in diagnostics, AI algorithms to analyze imaging for better prediction of shunt success and disease progression. By integrating these advancements with traditional methods, the management of hydrocephalus continues to evolve, improving patient outcomes and quality of life.